got, as you know, a very old dog at the moment, and it's just like really tender times at the moment because like every day is special with him, and I think it's really actually made me realise, like, as I get closer to potentially losing him, like how important animals are in our lives. And I've always known that, but it's kind of been like a bit more of a reminder to me recently. So I think, yeah, I'm inspired to do the work I do because I love animals, but then I also really enjoy working with people. The other thing that kind of inspires me at work at the moment is like trying to help vets in practice with their cases who are struggling, especially with the pandemic going on. Yeah. And then also just training people. Like, I was really fortunate to have really, really good mentors, and they supported me and helped me like reach my full potential. So I love helping vets in practice, and I also really love teaching the interns and other vets in the hospital and like learning from them as well. So
on the back of that, do you have any good advice for our general practitioner friends?
I think it's a really hard job being in general practice and having to try and do everything under a lot of pressure. So I would say try and look after yourself as best as you can. And it does really matter, like the times when I've made, errors that have resulted in harm to my patients, which we all do, and it's awful, it's a horrible feeling, but I can always look back and say I was exhausted, there were not enough of us, we shouldn't have been taking in these cases that potentially maybe we could have prioritised our emergency or critical care patients first, or perhaps that procedure that was a routine procedure didn't need to be done on this particular day. I think just trying to like make sure that the way you work allows for people to have breaks and to rest, and so you're not like to make as many errors and therefore feel bad and beat yourself up about it. And then also like get support when you need it. Like, we're referral centres, like we're always happy to give advice, even if you don't want to refer. Like, we'll go through the cases with you, particularly here in our ECC team. Try to see the positives in what you're doing. So it's really easy as vets to be like hypercritical of like your performance, and I think that can lead to like a lot of like negativity and feeling down about things. So I always try and remember, and actually this is one of my mentors, Aoife Sullivan, who works at Vets Now, she's great, and had a really tough case, and again, it was like the perfect storm of being tired and understaffed and busy, and it was Christmas, and I thought, God, I just don't want to be a vet anymore. This is terrible. I've made this awful mistake. And she said, whenever you make an error or whenever you feel things didn't go as well, don't just look back on the things that went terribly, but look at it from a different mindset. So say, okay, well, what went well and what could be even better? And then you're kind of flipping it around. So rather than being like, oh, I missed this and I didn't do that, etc., maybe you gave really good pain relief and that was really important. And you know what, you gave a fluid bolus and that was great. And perhaps you didn't initially realise the patient had pneumothorax, but you had administered some oxygen. And then what could be better next time? Maybe do a thoracentesis. It was a bit tachypnic, but try and like build on a foundation of like positivity rather than just ripping apart all of your kind of clinical practice, when actually that's not going to result in like a constructive outcome. It's just going to be you feel terrible and the same thing happened and you're actually not learning from it. So I think those are the things that have like sustained me in my career and helped me get from a point of feeling quite down about veterinary medicine sometimes and like my performance, to feeling that actually I'm really positive about it and there's loads more to learn and I'm okay with that and I'm just doing my best and my colleagues are doing their best. Yeah.
That's a nice way to flip the perspective.
Yeah.
It's very similar to the 3 good things, where at the end of a bad day you say, well, what 3 things went really well today? I like that a lot.
Yeah, and I think sometimes we don't even, like, we're so used to doing, like, just giving pain relief to an animal in pain, and a lot of us take that for granted, but, like, you know what, if you weren't there, you wouldn't have had any pain relief, and actually some people maybe even don't give pain relief, so, like, the simple things, like, you don't have to be performing at, like, this super high level all the time, like, just getting the basics is totally fine, and you just build on it. But, yeah, the 3 good things is also a really nice way to, like, on your drive home, just be like, actually, I did okay today. Yeah.
A little decompress.
Yeah.
I'm grateful. I do have a commute getting here, but I'm always grateful for that because it does give me a bit of time for like post-shift processing and decompressing before I get home, and then I can transition into being at home a bit better.
Yeah.
And also, you brought up the point of the advice. I'm not sure how aware people are that they can call us just for advice, especially out of hours, because we get a number of calls. I really enjoy that as well, talking to people, and it's like, I've got this case, it's a little weird, can we talk about it? And they don't necessarily want to refer, but they're just looking for a bit of support. And people are always welcome.
I so love like seeing someone else succeed, and it's really nice when someone's calling up and they're like, oh, we've got pericardial effusion and I've never drained it before, I don't want to drain it, I just want to send it to you. I'm like, well, can we make the drug more stable, could you drain it and I'll help you. We've got technology now, we've got like video calls, you can send us videos, we can talk you through it over the phone, and it's just really lovely when you get feedback from the vets, the following day or after the procedure, and they're like, oh, I've never placed chest drains before, but I did it, and I'm so proud of myself, and it's like you go on a little journey together, and it's great. And we've got like people here 24/7 who are super experienced, and I think the majority of us are super happy to give advice. We've all been in that situation before where we're like on our own and struggling, and so like we've been in those shoes, and it's not good. It's hard. So yeah.
Amen.
Yeah.
My wife's an optometrist, and she'll see patients with corneal ulcers, but it's sort of out of her scope of practice, and it would typically be a case she sent to A&E, but all of the ophthalmologists at the referral centres have set up a WhatsApp group for their like local cohort, so they all share photos and cases, and it's so comforting to have someone say, yes, it's okay to do this, or no, we prefer you do this. So, well, what about your ECC hacks or tips and tricks? You got any good ones to share?
A lot of the stuff that I found useful probably has just been through failing quite a lot, like trying to like do it as the textbook says, and it never really works out that way. So I think like my overarching kind of bit of advice would be that you should prepare to fail. So whenever you're doing something, just think, and not in like a failure is necessarily a bad thing, but just think, okay, I'm gonna do a pericardiocentesis. So what could be the points that could be challenging? So okay, the patient might develop arrhythmias, so should I have some lidocaine ready? Maybe the patient might become a bit hypotensive, so perhaps I should have fluids attached and get ready to give a bolus, and we need some monitoring on so we can see if they're having arrhythmias. So I think like just spending a few minutes just going through all the potential points of failure and where there might be challenges, and then coming up with mini solutions, and doing that with your clinical team. So if you're working with a nurse or another vet, doing that together so you all are aware of what sticking points could arise, and then kind of getting ready to prepare for them. Even things like, okay, we're going to be focused on unblocking this cat, but I've also got a really unstable dog over there in the corner, so what might your problems be if this takes me 45 minutes, and can we troubleshoot those initially before we get started on this procedure? So just kind of like having that moment of thought, and then just little things like don't worry if it's not perfect. Like I remember I used to get really frustrated when I was trying to do like pericardiocentesis if I couldn't drain the whole lot, and now I'm literally like, I'll just poke a hole in the pericardium, drain the chest, whatever, it's fine. Like I'm blocking cats, so people get a bit worried about it, but I would normally say that you have to actually do quite a lot more flushing than you think you need to do. So, they'll say in books like general anesthesia or a good sedation, but my top trick is to like get a slightly smaller syringe, so maybe like 2.5 or 5 mils if you're really struggling to unblock, trying to straighten out the urethra, and then really pulse like quite aggressively. So as long as you're not pushing with the catheter, which is absolutely essential that you don't do that because it will tear the urethra, the fluid that you're flushing and just gently trying to advance, it's going to come back. It's not going to explode the urethra. It will either push forward or come back. So I think that's another trick that I've learned, is just give it a bit more oomph. But just be clear, that is definitely with the flush and not with the catheter. Yeah, you've probably got some as well, haven't you? Like you've done a lot of procedures, so.
On the topic of what you just talked about, I think that was some of my favourite advice you gave me when I was an intern and a resident. We were working together, was about the idea of a shared mental model with the room.
Oh yeah.
Because I'm often in my head running around doing my own thing, and you said, well, you know what you're up to and you know where you're going, but no one else does.
Yeah,
so
it's true. Yeah.
Share with the team what your plan is and what you're up to, because getting everyone involved and knowing what is actually the plan and what's going on is super important.
Yeah, I don't know whether I'm annoying doing that, but I feel like I kind of want everyone to know what I'm doing, but equally I want to know what everyone else is doing, sort of thing. It's like a hive mentality, I suppose, isn't it? And then you all kind of are on the same page and working. And I think also it takes a bit of anxiety out of emergency cases, because if you say, oh, we've got a GDV coming down and it's really stressful, then your nurses, your other team might get a bit worried. But actually, we've got a dog coming down, a bit bloated, might be this, might be that. Getting your thought process out. Yeah. This is what I'm considering we do first. This is what we might need ready, and it just sort of like calms everyone down a bit. Oh yeah, and on the other topic of top tips, I wouldn't bother trying to place an orogastric tube in a dog with a GDV. I mean, I've tried in the past, and they just hate it. Like, it's horrible. Like, who wants to be conscious while you're having a tube shoved down your throat? Yeah. So for decompression, what I usually do is I'll give them some methadone, get them on their side, find a really tympanic bit, and then just stick a big old stylet from your catheter in and just and it'll come out. If they've got a GDV, which you've confirmed with your right lateral radiograph, you're going to go to surgery anyway. So hopefully there's not going to be a significant amount of gastric leakage, but if there's a bit, you're going to wash everything out. The only real risk is maybe a bit of a laceration to the spleen, but if you choose a nice tympanic bit, and you can even confirm with your ultrasound, looking for that bright white gas line and making sure the spleen's not there, like, you'll be good. Save the patient a lot of stress, save you a lot of stress, and potentially less likely to have regurg because you're sort of trying to fight with them to get a tube down. I think that's another thing you get told to do in the books, which is fine, but in reality it's pretty hard.
So to be clear, if you're not going to surgery with the patient, doing a trocar is inappropriate?
Well, I guess if you've confirmed they've got a GDV, then you're going to surgery or you're going to heaven. Yeah. But if they've just got gastric dilation, I would probably not want to do a trocar, because I suppose the risk is you could have some leakage, and that could then cause septic peritonitis. So I probably wouldn't be as confident to do that. Yeah. My kind of thought process when they're like really dilated and they're not rotated is, it depends what the cause is. If they've eaten a lot of food, it should just hopefully pass a bit of rehydration and things. Yeah. Maybe for that, I would probably be a bit more inclined to consider the orogastric tube route. But also, sometimes I just leave them, closely monitor them and see how they go, and it hopefully will come down. Yeah, but I wouldn't probably trocar those ones unless their stomach's rotated and I know I'm going to surgery.
My favourite tip is blocked cats as well.
Oh yeah.
And this is from Hattie Syme.
Oh yeah, that's going to be good then.
Oh, it was stay sutures.
Oh yeah.
And it seems really savage, because you are essentially extruding the penis and putting stay sutures in that tissue.
Through the penis?
Yeah.
Right.
But you can then extrude and straighten with one hand without the help of anyone else, and it makes flushing so much easier.
Yeah.
So you just get your stay suture through, you get your loops through, clamp those so you've got the loop secure, and then you can literally, with your non-dominant hand, both straighten and extrude the penis without having to use forceps or having an extra person, so your assistant can focus entirely on monitoring the patient, and you can unblock with two hands with minimal fiddling. So if they're in right lateral, so we'll extrude and just find some, let's say if the cat's legs are this way, then I'll typically get some suture on that side of the penis. So it will be extruding and getting full thickness just on one side.
Okay, so you're not obstructing your catheter going in, you're just doing it on one side. Yeah. And I think also, like, yeah, you're right, that does sound pretty savage, but I think sometimes we see cats referred in and people have tried multiple times to extrude the penis, and actually they've caused like quite a bit of bruising and trauma just from repeated attempts, while they're catheterizing. So maybe in a way it's a little bit kinder just to be like, right, we're just pulling this out, it's going to stay out now, and that's it. So do it once, do it right. I don't know.
So have we got any fun, new, interesting developments in the land of ECC?
To be honest, I don't know how new it is, but for me, I think the thing that is really changing, maybe two things actually, really changing like how ECC can be done in general practice, is the use of, and also in referral centres, but we've been maybe using it a little bit longer, but the use of point of care ultrasound is just like revolutionised it. Yeah. to the point that I have to remind myself to actually auscultate chests, which is really naughty. But yeah, I think it's so useful. You know, you can, looking at the heart, you can say, have you got a pericardial effusion? How does the left atrium look from a volume status? Like, are they overloaded? Are they underloaded? What's the contractility? You know, the lungs, is there pulmonary parenchymal disease? You can pick up nodules, pneumothoraxes, pleural effusion, sometimes big lymph nodes, and then the abdomen. I know that it's kind of just meant to be a free fluid check, but the more you use it, the more competent you get, and you can start like seeing things, you know, that are really helpful actually in your diagnosis and your workup of your patients. So if I had money now in a CPD budget and I was in general practice, I would invest that all in ultrasound, because I think it's just so helpful, and you know, you can get a left atrium aorta ratio in like 10 seconds when you're competent with it. You know, and I teach vet students to do it. I could teach a nurse, I could teach someone in the street to do it. You know, it's not hard once you know, and it will completely change how you do your daily work. And then the other thing is, which I'm quite excited about, is the use of like high flow nasal oxygen now. Super cool. So obviously sadly with COVID, like we've kind of been using this a lot more, and there's a lot more literature coming out about it in like human medicine. But I think it's something, and I don't know how much they cost, but you know, if you've got the budget for it and you're a big practice, or like you've got a hospital, then I think it would be a great thing to have, because it really does save a lot of patients in a referral setting from needing ventilation. And the same in the NHS, they found that actually a lot of people that they previously would have ventilated, they're finding that they're actually managing okay with the high flow. You know, it's humidified, it gives them lots of comfort, you can get quite high liters. You know, there are some downsides to it potentially as well, but I think particularly, you know, dogs, I've only used it once in a cat and it was a little bit challenging, but you know, in dogs it's really great, and it kind of bridges that gap between just normal supplemental oxygen and then ventilation. And so I think it would be something that would be very useful in referral centres and also in primary care practice.
Excellent. Well, thank you for joining us today.
You're welcome.